ላይቭ ነው
እኮ ላይቭ ዩቲዩብ ማለት ነው።
አሁን የጀመርነው ከምሳ በኋላ ወይ ማን ነው እንትናን ጠይቀው እዛ ጋር
እሺ እንትን ግሩፕ ሌላ ነው ነው የማን ሰለሞን አለ አሽራፍም አለ
I would like to invite Dr. Cesara and Dr. Said, along with Dr. Jim, to moderate the sessions. Dr. Said and Dr. Cesara, please come to the stage.
የታለ ስሙ ማን ነው? ስሙ ማን ነው? ገብቷል እንትና አሁን ነው የሚያቀርበው?
So the first speaker is going to be presented by Dr. Nathaniel, who will be presenting via Zoom on accuracy in predicting implant size by ESOT with and without radiographic marker in plastic, review, followed by Dr. Sanomu on redefining public-related view angles in Ethiopian population. And Dr. Shomatena, also via Zoom, will present on determinants of early complications and figuring factors following operative management as center resultant study. And Dr. Brunusu on orthopedic post-operative infection profile and antibiotic sensitivity of 2,038 patients across 24 countries. And finally, Dr. Ashraf Jumento, prevalence and associated factors of surgical site infection after intravenous nailing or open finger fractures. So we've officially begun our afternoon session. Dr. Nathal, go ahead.
እየተሰማ ነው? አይ ቲንክ አሁን መጀመር ይችላል። ያንተ ድምጽ ግን እየተሰማን አይደለም። ቼክ ላድርግ ብዬ። እሺ ፕሬዘንቴሽን ብቻ ነው የሚታየው። ሚውት አዎ አሁን መጣ። ይሰማል ይችላል።
Dr. Ahmed, can you put your slide on slideshow? Nathan, can you hear us?
አዲዮን ነገርኩት።
Dr. Raymond and Dr. Mahmoud from the stakeholder, during the 17th Annual Conference. Today I'm going to share our research on accuracy of predicting one decipher disrupting taking into different meters in acroplasty, and our paper is published in journal this year. So this is my outline. So as the introduction, deep fracture are the most common for deep fracture. Deep fracture every in probably 60% amount of human fracture, and the only the means of treatment for all the individuals systemic fracture. Saying this, the operating disability has been specifically plastic is also the extent to plastic, and that's got importance in significant scapular erosion, but not contained transmitted, and what is research meters and patient factor as data of contribution to the hospital. We use either external radiograph method or some of the documentation. So the aim of our study was to assess the accuracy of the 250 meters like pixel manipulation pattern and the external radiograph method in predicting the image size. So when it comes to our methodology, prospective review, it's conducted in all patients who undergo plastic organization of manufacture, and here are our treatment criteria for patients that face X-ray with external radiographic manipulation or activities, including our study, patients with documented abstract of the site of the chart. But patient is contralateral in angioplasty with X-ray from our study. So this shows us how we got our sample. So there are around 100 teachers for whom angioplasty was done in the past 1 year, and from these, we only 54 patients have located X-ray. From this X-ray, only subsequent were adequate, and 2 of the subsequent patients doesn't have the documented implant size in the chart, so our final size were certified. So when it comes to data collection, so we prepare stationery, which consists of photographic pattern, orthoplastic implant related information, and plating related information. So when it comes to the preoperative templating technique, so what we use is radial software, and templating was done on the unused or normative by 2 of the first, and they were blended to the size of the definitive implant we used, and also they were blended to each other measurements. So the female size was determined by measuring the widest diameter of the female head, and then the derivative measurement was calculated using 2 meters. The one is external radiographic marker, and the other is but before we using the second method, we need to know our magnification factor, our precise magnification factor. So in order to determine the magnification factor, we use 15 direct X-rays with 16 millimeters over the DD, so that you can calculate our magnification factor by dividing the actual suicide, which is 16 millimeters by the calculated suicide times 100. So we got a number ranging from 116 to 120, so that we calculate the mean and the minimum patient factor of 180. So this is the minimum patient factor of this size. So to calculate the thematic size by using the magnification factor, so what we do is just measure the thematic size of the X-ray and we divide it by the number of 180. We got the thematic size. So this is for meta. So I can show you on this picture so that you can understand it better way. So what we do is we measure the widest thematic size along the length of the corner, and it's around 40 to 80 millimeters. So this is the delicate measurement. So in order to get the actual size, we divide this number by the magnification factor, which is around 41 millimeters. So 41 millimeters is the size of the MIH that we predict using millimeter. But for meter one, what we need is after we measure the MIH size directly in the X-ray, we go and measure the sphere, and then we calibrate it to 30 millimeters. So automatically we calibrate the field, the image size also will be calculated, and it shows 40 millimeter of data. So using meter one is 40 millimeter, and using that one is 41 millimeter. So after we can get every X-ray, then we try to process and analyze our data with the mean related period for moving the source activated compared with the services. And finally, the observer having for the system comes capable. So, in terms of result, applications in a capacity were done from the challenge. So, that we see here, and from these applications, made the inclusion criteria, including the male and females, and the average age was 7. And in terms of implant age, with bipolar, with unipolar, and 8% age, that's 7 months in the and the average implant size was of 2 millimeter for the females, and when it comes to the accuracy, so we put our accuracy as a percentage, so this shows the accuracy of each technique just done by the aim of the B. So as you see in the first column, the first column will show the difference between the templates and the actual size. So the maximum difference we got is 4 millimeter up or 4 millimeter down, and after we calculate this difference, we calculate the percentage of agreement. So for exact agreement, that means the difference is 0. The observer A calculated length of 1 of the patient exactly the thematic size, and observer B 25% integrated the exact thematic size. And when you increase the level of agreement to -1+1, the percentage, the accuracy of the percentage increased to 63% for the meter 1 and 60% for meter. And when you increase the agreement level to -2+2, then for meter 1, the accuracy increased to 85% and 77%. For meter 2, the accuracy increased to 80% and 77%. So this is a table showing the mean related period. So the mean related period for meter 1 is around 2.8 and 3.1, and the mean related period for meter 2 is around 3. So as you see from this table, the mean related period for meter 1 is lower than the mean related error of meter 2, but this difference is significant enough. So we try to compare using independent TS, and the p-value for all of that was 0.46 and 0.459 is 25% confidence interval, and which is insignificant. So finally, we assess the interval agreement and using comes kappa value, and the K value of the exact measurement agreement is interval and negative 1.06. Factors usually is low, but when you do the precision scheme, say by just 1 millimeter, then the kappa value increases to 0.84 to 0.9, showing the excellent intervals of the argument. So, various papers in Canadian creation shows that fixed magnification factor has an equal or a greater accuracy than radiographic marker method. So you can see the paper done by Frank in 2010 UK, tries to compare 45 meters, but is actually progressively finally what fixed magnification factor has equal accuracy
ይሰማሃል?
and has a greater accuracy to
ይሰማል በእርግጠኝነት
and there is also another research done by Veras by 2022 by using a signal magnification of 120%, and this is and in this research, both of correctly the size down to 2 millimeter in 90% of the cases. But so in conclusion, this ability of keeping up class using a fixed magnification factor as accurate as the external size, and shows excellent reliability, and using this method we avoid the extended or some we recommend that disaggregating of final exercise using a segment which partner can use as an alternative. So it's again, we want to talk some that is data to all sides of anaplastic plan with the patient because as you see from the previous studies, in around 20% of kids you can be treated using treatment by any of the needs. So finally, we can doing restore inappropriate in the anaplastic. So it's recommended that all the sites in the operation have to stop. And as I recommend also radiography technicians should take adequate and take safe from distancing researchers programs hospitals that use a larger sample size. So our limitation is mainly sample size, small sample size. It would have been greater for such accuracy if the sample size was more. And the other one is the retrospective feature of the study. There is also the other limitation. We could have compared our calculated results to the mainstream site, usually talk with comparing it to the site. So finally, I would like to start at the University of Science and Technology for having the postgraduate program. And these are the references which I used, and this is what I have. I'm going to
Good afternoon, everyone. I'm Salomon, Hospital from Special Hospital. So I'm here to present our notice. So our patent is defining complicated outreach beyond in the Ethiopian population. And put us on Mr. Gabriel for this paper. So I have an exciting story. That's what we translate. That is open access for publication. So these are the outlines of my presentation. So we have some backgrounds of the basic design discussion, conclusion, and finally recommendation. That's first. So as a background, clinical practice is quite common. Around 8% of all fractures, even one study then fractures with a combined vascular fracture accounts for 16% of visits to the hospital. So this fractures are very serious. They can lead to death unless they have monitoring. So in this development fracture, it requires for the clinical surgical evaluation to treat the iron. So when we order clinical cases for patients suffering from fracture, so we are order continuous therapy, we need an applications. So whenever this available system is in the midst of diagnostic modality, but it's not available everywhere, especially in our country where there is significant limitation for the system ability. So the research that showed that there is significant variation in the technique morphology across different systems of ethnicity. So the usual group of X-ray does not align with optimal for our patient to diagnose the treatment and the complication due to additional radiation exposure as well as additional prices for X-ray. So the objective of our study was to determine the ideal values in our population and then to identify factors that are causing its arms in our population. So our main was study design was procedural study design. Around 148 patients who has abdominal disease scar, but the indication of others and full pathology like or problems in the abdomen. We call it guys who are older than 8 years old, which I classified is not as well as normal, which is the criteria, 5 7 criteria. So this criteria was actually something and then normal center. And then with the seat diagram, we just extract the point and we load it. And then we use radial diagram software for measurement. So the outcome variables is determined by the mechanism of the population, and then factors that are positively affecting the age, sex, and anatomy of the subject. So the technique used for the measurements of these are the most standard technique I think based on its extract from the previous study. So as you can see down the slide, so we move this up rather than computers, and then there is a function it's a CDN. So on CDN, we can start these features, the research and construction, and the research and construction. On the first picture there, so there are 3 lines in the picture. As you can see, this is the diagram line, the line that passes the city schools and the center of the center. So we do have 3 lines: the gray line, the red line, and the green lines. So the green line is perpendicular to the gray line, the line of the system, and then the red line is the line harmonic with the straight field of S1 with the inherent field of S2. So that will go by this green line and the red line will give us the ideal elements, whereas for our elements, the image is one sequence of the parasitic over the superior classes. So the line, so the green line is the alternative the green line. The red line, the line that passes the superior portions of the superior classes, and then the middle portions of the. So down followed by the red line and the green line will give us the idea of the numbers. So we also measure the numbers of something numbers using the other technique on the x-axis from the CD on the chart. So this left side rotation, side calculation. So when this is the image generated the image. The site image when we incline in this position, we get image to be around 3 on the picture, and then after that we also determines to be code so we do the mix and construction as well as the single image for measurement of the making of the values. So this is another version of analysis with simple logic equation by equation, and then this is the so we want it around 114 algorithm system, and then about using this concept of rules, and then we have 45 years. So this initial shows about 54% was student center, and then 46% are non-group center. So this table shows the result. So the update later will be determined using the insight and expansion field. So as it is from the table, then the update of the have to be determined is 40 degree, and the number of elect is almost similar. There are sufficient parts, and A side is also elite side for the application, using almost similar A side to the maximum 55 degree. So when you see on this table, the degree determined on the using the single as well as the site and construction, the average degree was the same. So this table also shows after data with the measurements, and when you see this table, so they have relatively higher weight and images is versus 20, so those are significant. When you see the data, it was significant, it's 39 versus 41. This significant, but it's not correctly significant. So when you see the normal is sucker. For this one, sucker design is in the angle of about 60, whereas this was significant. So as it increases, the angle also increases. So the different degrees have been reported in the literature for the boundaries. The first picture shows how we take the effect, and we can make a color of the cranial so the data from our study shows that the meeting of the numbers in fact respectively, whereas the touch and the classification was correlated out with 45 degree, but it was on it wasn't based on the external way. There was no strong evidence until the clinical imagine violation on the 8 was 35 degree and the was 60. Even another study which was using the construction showed using 825 degree, 45 degree, and then which shows at least similar to and so similar to South countries, which is some of the basic ethnic base difference in the morphology of the sacrum. So outside also makes some greater and nothing images, which also supports this population variation in morphology of the sacrum. So all these results highlight the complex relation between the sacral morphology and the beyond the population. As a conclusion, the basic idea of the analytical is for the functional parts of the 45 to some absolutely orthogonal like 45, but it's just the benefit of the understand the normal orthogonal X-rays as the treatment of see that measurement is also another cost easy active measurement. When you see some available, there is some component of the push of the variations in the as a recommendation, see that the the 40 degree, and then so we talk the very common of the prostate cost and trauma issues, because also then trauma issues, so we don't want the trauma products, what the trauma those many operations that you so we don't have the prostate cost and trauma issues, and then see the trauma, we especially for our surgeries. So I have one together with the Department of Orthopedics and the Department of Special Staff to give the chance to professors and to achieve this data. Then we have also developed this as necessary for awareness as well as for cyber care international for the environment support contribution to our policy program. And then for our training as well. Thank you so much for making the class. Thank you.
Outline of my presentation. Would be that immorality. Meaning treatment with a healing in 3 to 5 months. That's not usually 100% healing. So we research shows that 30 to 45% of patients develop complications and mainly fixation data. Patients may have with complete healing. Some patients, as you know, they develop memory or healing and fixation data. So why we need to study? Well, we study on the outcome in a project in our country or in Africa in general. So hard. And the other is to know what determines factors of outcome treatment. In our data, presently there is a controversy on the effect of time surgery in our practice. Objective or general objective to identify determinants of clinical cases in our fixation is objective. One is to assess the prevalence of clinical complications, which identifies factors for complications. Generally, study areas for instance, prevalence positive from from many other also, population is all in agriculture who typically start during the steady period and steady population is all in agriculture fixation. The selection of including criteria is age 18 to 65, 6 months of follow-up, and use complete data. Excluding criteria, complete data, so this data use fully. Our outcome variables is fixation data, which is we define fixation data as also fixation growth and displacement of the fracture within 6 months of treatment. And unique AV. So we collected data from the patient charts, radiology records, operations, follow-up electronic documentations, usability, in exchange export to test cases and in analyze. result was total of 757 human patients visited during the study period. Of these, 104 patients underwent human visit. 78 patients included in our study, 13 patients with incomplete data, 9 patients with bleeding, and 3 patients with more than 18 years old, and 1 pathological fracture patient excluded from our study. So, demographic and clinical data, you can see on the table, that male accounts 73% of study population, and smoking is the common comorbidity accounts 3.8%. Road traffic injury accounts 38.5%, followed by food points and health, which is 30%. And this geographic classification, food person followed by having health. And this road of the accounts classification, patients are in falls under the type 3, followed by type 2. And unlimited is currently used for 85% of patients, and for the remaining 18% of patients treated with NMP score. And growth reduction is achieved in 61.5% patients. And build alignment index, which shows the quality of reduction needed post-operatively with a region of the clavicular values with the median cortex sativa, with terminal septal when it's range from 155 to 180 degrees, and terminal septal is out of this range. And 72% of patients have acceptable reduction, and the remaining are unacceptable reduction. And the division them into mass reduction and displacement for 9% of patients. And we can from injury to the date of surgery was 17.8 days, the median starting with 5. And the total amount of complications is 7.4%. And for this, safety data accounts 25%. And then means 7.7% indicated is 3.8%. So with primary analysis, we found that students we classified into many clusters. This cluster is associated with early complications with 0. P-value of 0.038, and ours and greater than 70 degree is associated with the early complications with P-value of 0.052, and greater than 11 degrees with unacceptable reduction shows a high association with complications with P-value of 0.001, and limited also the boundaries for early fixation with P-value of 0.005. With multivariate analysis, we found only certain alignment indexes are associated with early complications with a P-value of less than 0.001. So, as discussion, we found that non-acceptable index statistically significant risk factor early complications in giving safety. and there is no association between the dermal surgery and family complications so far. We found a high incidence of family complications in all three fractures in unknown greater than 70 degrees. And the aim of our study is first study will serve as a benchmark for your study. So weakness is very prospective and short follow-up time. And not sure what the AGM patients. Conclusion, unacceptable certain elements index and immediate post-operative surgery or examination is for the early complications. We recommend anatomic reduction irrespective of time during surgery. Our reference. Thank you. If you are ready and forward.
Good afternoon again, welcome. For the coming period, we will see also on micros. So this is microorganisms compiled and research pattern also for research application. So this is the evidence for microscopy. And the goal is to correlate and institute specific such as associated guidelines. So since the study was finalized able to that. So maybe studies that I have studies financial supported by allowance, so we will see the definition of the study, why one test to study, objective, maintenance material, result, finally goal is assessment of the why one test to see this one, where we want some also creating such as education. That will be one of the most important things. So such properties. One, also British classification, it is the beginning of mortality, and it's also one of the also chronic hospitalization associated with a catastrophic health due to expensive treatment for such a condition. And the other important thing, it has multi-directional impacts on patients, community, family, as well as health institutions. And the most important thing is the last dose, which is with microbiological resistance to the antimicrobial. So this microbial resistance or the antibiotic structure will be for the material resistance and finally to be one of the difficult in 2 months. So when you see the incidence of such classification, there is a study which was done by the global surgical team, and they reported it as salmonella or high income country, and it will be developed for middle income country. So it's possible for middle income, and finally, the low income country will have 20%, right? 20%. So it's also to risk a lot of resources, and you can imagine how much it is difficult for the management. There's also another systematic review, which was then on sex, then only in Africa, and they reported as the prevalence of incidence of, so this incidence of such classification risk from 2.5 up to 30%. So there is a wide range from region to region. The incremental also mutation and also creative movements or also creative operations to be provided. Organisms which are incremental particles. Most commonly is the leading cause of mutation from pressure as well as sex pseudomonas or ginseng supports. There are a lot of bacterial machinery, a lot from the gram-negative species as well as Candida concept as one of the cause for such type of mutation. Another key point is the multi-direct resistant microorganisms, and it is reported as 37.5% of the microorganisms classification also multi-direct resistant. So from this, we can anticipate how it will be challenging to resist patients. There is one study from Indian more than 400 patients, and the prevalence of MRSA, meteorological systems are also really high, 55%. 55%. So this is all an alarming number to consider. What is the rationale? What is the significance of the study? The rationale was like most of the study it was done before. They have basic concentration for very income country. They are done as in middle income country or high income country. Rather than most of the studies they are from a single center, they are retrospective with small sample size. Small sample size. So it means there could be bias. So we need to example. But the key point is there is no variability among low income countries most and this way. That's why we want to conduct a study to be this one. We will plan to address this study alongside geographic variability of the positive microorganism. And we believe that this study will have a significant impact on utilization of institutional, regional, as well as national protocol development work and verification. The reason is that microorganism from region will be different. Objective was to identify the most common microorganism which cause mutation associated substance in finally until antimicrobial resistance pattern was the main key objective. The study was a very international study. It's a kind of cross-regional study. We're using the statistical data. We include 24 countries from 5 big regions, including just Pacific region, Southeast Africa, West Africa, Latin America, and Middle East, East region. So these four, which are highlighted in this red box, are represented for this. In the next parametric cross-region, identification more than 8 years old who have such as a complication after operation, they are included, that's very close to three. By short components are excluded. Patient is replacement, either hip or knee replacement, then other replacements to be included. The spine surgery and for genetic spinal included and orthopedic components surgery included in why? For concept, patient is a surgery as current operation site, patient who have infection as a site, delayed infection is not weak, and the patient who is manually engaging in management with expertise that different factors. Sometimes it's calculated by online sample calculator, considering this four factor to cover the same. So I will show microorganism frequency to taken as 20% or 1% and the margin is 0.5%, confidence is 1.5%, and since we are using rigid and country in institution, we use a daily type of sample. So we use exactly 2.5. And finally, the total sample is 2,038 patients. One patient who have surgical segregation included and previous. We diagram from Manchester, where I was in my fellowship, we developed structured questionnaire for the extraction and the data extraction was integrated into applications, like the data. All the scientific statements of the students graph for the code to data. And the data was approved by the PI and there was also personally to identify the subject. These are the data that we collect from administration, patient characteristics, bacterial profile, and antibiotic sensitivity collected. Once it is the data, we extract from code to different species for clinical analysis and the distribution and images. We use the results of the social characteristics, cell production, as I mentioned, 1,000 segregation from the country, from a type region. 64% of the patients were from the age of 19 to 60 years old, and 82% of the patients were needy. When you see the region from Asia Pacific, we have 9 countries, including 1,702 patients, Southeast Africa, 24 countries, including Tanzania, they contribute to 341 patients, Latin America, 195, Middle East in UK, 158, West Africa, country. We were able to recruit 8 type of surgery. Most of the surgery traumas or selected patient person, spine surgery account 70% and 20% implant use. We use implants for 93.5% of the case as a patient will have implant use. Like, for example, if you have an application, the type of implant Sales still accounts nearly 60% for the item. And when you see the application is a structure of 2% of the application rate from the surgical site application is on CDC care. Patrick Walker, based on the region, the specific points that I want to mention is based on the 5 regions, the type of microorganism which was application completely different. For example, there is a little predominance for gram-negative xanthato, gram-positive, not success. 1,024 from gram-negative, 1,014 from gram-negative was high xanthato, gram. And the two regions, the Asian Pacific as well as Latin America, the most common cause of infection rate found to be the gram-negative. Specific bacteriology, gram-positive, from the gram-positive, some also the leading cause of infection, 5.5%, followed by epidermis. And unlike the previous where after the 55% here, it is, it is 2.6%. From gram-negative, you say there is a leading cause for the rest of the equal. You see, the area specific again, Asia Pacific and others actually, supports the leading, followed by Brussels and Pseudomonas. In the West Africa is completely different, right? The leading cause is 67%, followed by Pseudomonas and supports. So, things like we have different type of bacteriology which shows infection at different levels. Under sensitivity, 89% of the surgeons they reported that they use cephalosporin as prophylaxis, either precise and also regeneration. Similarly, cephalosporin reported 90% of the patients. So there is bias. That is one of the signs. When you see the antibiotics with great sensitivity for gram-positive bacteria, includes this one, only gentamicin, amicacin, Benzoyl, and piperacillin, were having a good sensitivity related for gram-positive. Gram-positive for the gram-negative, amicacin, erotin, and gentamicin is found to have a good sensitivity example of cancers. As a discussion, we believe that this study also is a kind of descriptive study. It highlights the variation in bacterial growth as well as antibiotic sensitivity based on the different region, which necessitates the need of performing the prophylaxis of antibiotics based on the region. So, for each institution in the region to have their own protocol based on the microbiology identified. There is a balance, as I mentioned, resistant versus the use of prophylaxis. That's also another point to focus on. And there is also an explanation. We can outline an explanation for why we have variation in microorganisms. There are the 3 differences. One is different geographic distribution, that is different resistance pattern, and finally, they have different surgical different. So these 3 Ds will be cause for explanation for reduced vital as any research, this is a limitation course. One of the limitations is being retrospective in nature. We literally being retrospective affects the result because we use microbiology assessment, which is generated by the computer. But still, it is a prospective study. Some sites is different among different regions. You see one, for example, Asia is 1,700 while others is 100%. So there is variability. Heterogeneity also there, different processes will include, that's also another theme, and data values for bacteriology isolation. Yeah, so lack of validation bacteriology diagnosis, we can't control, it is a control factor that should mention as one of the implications. But of all, we believe that this study is one of the largest studies of infection to show the various type of microorganisms and antibiotic resistance pattern in global medical countries. In conclusion, the message of this study will be each institution as well as region need to have their own institutional protocol based on the prophylaxis and for treatment purposes based on the cultural sensitivity. This is the same. Thank you. welcome to again this this is a paper from partner university. Is already working finally on prevalence infection after the exam. Certified implantation with the sign of infrastructure and special stuff. So these are my presentation plan, introduction, objective, latest result and composition after recommendation that group as introduction, certificate certifications according to CBC and NHS criteria, and surveillance infection is infection, certain infection with implant, and within 30 days to certain without implant. So those are asked for possibility in the working and with this certificate certification. Open fracture, higher this communication in communication. Intermediate is one of the establishing this open fracture and certificate certification related to intermediate is serious and difficult to once it is happening. This complication because delay or the fracture will increase or sometimes in amputation. So certificate certification posting convert the patient in his case in terms of prolonged stay, the same time this is investigatory, there are postcard going to disability, contribute to speed of employment resistance, including investing in substantial financial burden in his case system as the patient, the family discouraging fast popularity in amnesty days. So so this study assesses the prevalence in the three factors of this certification. The result of this study will provide manager of so objectives, the general objectives to assess the prevalence in the three factors of this certification assigning for human factor. So specifically determine the prevalence. This certification in the specific when this institution is the source of patients which are spoken fever market were admitted from so this study population of patients admitted with the young community factor operate with deciding for so during criteria and including criteria, so patients who are fully from the start or including data from database patients who are the statistics known, which is calculated in the database or the patient who are represented on the site because they have to run in sample size. So this is another that the outpatient with 6.5 years, the outpatient operated with this sign with the open treatment factor under field 5 from this thing. Then we have output. This is study into the output. When you see data collection project, structure question where the data collected from scientific database, and then release the chart, data collected, and in one media they trade. So study variables are variables. There are variables dependent variables, which are operational integration, When you see data processing and analysis, that also goes deeper into using people version server and install for analysis. Basic access, window version when it's security service like progress so the standard for that 150 study partners were enrolled
So the mean age of the first is what? More than 7 years, and trauma, when you see the trauma, very good is the commonest in 71.3%. That time we did one time in the northern part of Ethiopia. That's how many is the commonest. And like the commonest trauma. This was the demographic, and we calculated that you see the prevalence. So almost certified was around 12.2%. And the development of this certified condition and parties before and after 6 hours of improvement, 6.7 in 17.85 and 85% respectively. So patient who operated one in more than one environment again, there is difference. More than one environment is 25%, in those who are only one environment, around 6.3%. They develop certified certification. So these are the factors which are decided by the situation. Lastly, we have two variables which are clinical significant with the multivariable segregation. So these two are the prevalence. So when you see almost similar, this prevalence is a bit lower than the study in Israel reported almost. In almost 30.6%. So similar with the overall prevalence certification in post-operative education in Utah, almost 12.3%. In the lower in Mumbai, in Dar es Salaam, almost 25%. In the higher science community branches, we are fractured in India. So so patient who took antibiotics 6 hours of from 6 hours of injury are 3.98 times more likely to develop cervical certification compared to Kutu antibiotics before 6 hours of injury. This is the commonest interval value. This was also similar in study in China. Even fracture, cervical site profoundly increased with diagnosis antibiotics, especially antibiotics is delayed for more than 6 hours. In study, those who operate more than one level again, almost 3.91 times more likely to develop cervical certification than those who are operating more than one level. This almost probability is that we say similar to this. Show us maybe this the description is in the operation shows the whole list is going more than one time. So this definition as the as completion. So the prevalence is going to 2%. Delaying time to start about more than 6 hours, more than one before the subject was very attached to this cervical certification. So recommendation for specific institutions for development institutions and development awareness for certificate to initiate what's patient alive and then as much as possible release for computer aspect for presentation to aware of this certification is complete permanent and by the state the ministry in 4 days. Researchers. So lastly, I want to upgrade for Barbara University in the orthopedic department to start in this effort. My advisor for Dr. is now in the department of orthopedics in Barbara University department in the center. That's for my colleague, that is
Okay, we're gonna take a couple of questions because we're running out of time. Anyone who has questions from the audience before we go to the moderators for their comments? Any questions?
I think we can start with questions. I think probably
Thank you very much. I have two questions. The first question is to the speaker. What I see is the number of males is very high, according to the females. It is, why is there any explanation for them? Second, to Dr. Mangistu, what you advise to our country as you study which antibiotics is preferable to be in some place where there is no microbiology studies or that clinically, some countries we do for our experience, what you suggest to this solution. Very very much.
Good evening, doctors. So my question was to production. So as you said, the prevalence of infection is reported is 30%. So if you classify another wound classification is not specific, clinical important. After classification of the classification rate, so really classified. And the second question is to Dr. So the risk of every complication is higher in those patients who have higher underlying index. So that's the post-operative assessment. So what is the rate? What's the post-operative assessment? Is that for early follow-up and early intervention, or what's your suggestion to get higher underlying index? Because as you see from the logistic regression, those patients who have higher underlying index are significant as early complication. So what's the recommendation for those patients to have underlying index? Thank you.
Thank you very much, Dr. Harun, for the nice question. So the question was, what can we say, which activities to use for data? And he typically mentioned the current scenario, which is most of the samples we don't have microbiology assessment. We don't have a setup to detect the microorganism that is sensitive. So how to handle it? So couple points that I can say in this study. One, first point, the clinical scenario, we need to identify the microorganism for each institution, because it's different for each institution, region to region, even continent to continent. So that is impossible, we need to do that. So creating the scenario, it is impossible. Now we go for we use similar setup, similar methodology. For example, in our study, based on the finding, we classify the 24 countries into regions. We did that intentionally because they have somehow similar microorganism identification. They have also similar risks. So now we look at, for example, most of the microorganisms, because most of the identification is ground, meaning they are somehow sensitive for even several. Because a big paper, one of the paper by the distribution of the so that is one point, which means we need to use similar setup steps. If we don't have plan necessarily, we need to use the set of them outside. We don't have plan to use we need to use the set them in outside. That's plan B. Second one, we need to always. We need to or we need that from the process. I know that will be too sensitive to say this. But the other option that happens, we can use other things like, for example, low energy can say anything,
we can resolve. That's what I can say. There is any idea, the key message that I want to present on this study, which is to have different microorganisms, because the microorganism is a resistant part, it's completely different. That's the most important. That's the problem is we don't have access. So this, I don't know whether I agree or not, but that's what I can say.
Thank you. Yeah, as you see, it's important if you have such applications which are rapidly some people really massive.
Okay, we can ask one or two questions for one of the countries. Do you think based on the study presented, I think 70% of the included factors of the included variables in the study were traumas related to trauma, and after a single study we presented like 10%. So do you think you can take that conclusion as the kind of organisms identified are common in orthopedics in general? Because the setup for arthroplasty, as you know, is a little bit different than the one in ESOT. Can we modify that? Very short injuries where you also mentioned that was because of the conflict in the region and so on. So how do you think that, how do you calculate that into all, because very short injuries in general, so we're looking at that. And also maybe one more question for you, and you mentioned that the repeat debridement is a risk factor for infections. So what is the indication of redebridement in your area? Because we do redebridements when the wound is not clean. So I would recommend you to keep it, even if it's not clean, you should go ahead with the execution.
Thank you very much for the question. Again, here is a point of generalizability. Can we generalize this study? Because some of the procedures, for example, recently there's 7% in the same class, and the 7% of the cases fracture or trauma study. Yeah, I clearly mentioned some actually. This study has a problem of heterogeneity, meaning the population that represents the study is not homogeneous, it's not the same. So only trauma, it's not only spinal, it's not only replacement. So that's one of the limitations. But still, whatever you do, the most important thing, everything like the background, how we can reduce this sexual satisfaction based on the adverse activity and the like. I will not say it has a good evidence to generalize for everything, but it gives at least something. It gives at least something. And the most important thing of this study is to see the geographic variability of the microorganism and the risk. It's not about generalizing. Is there any difference? Complex what we read is some most common cause of infection. But it's not true. It's not true. So, for example, in different celebrities, gram-negatives as a leading, it's known as the leading cause of infection. That was the definition of the study. Means that's the heterogeneous distribution, which is not homogeneous, you can generalize for everything, but it gives samples.
Thank you. So what I see is when you take this patient factor, the wound in Africa is very good, almost 70%. That is the contrary is happening common as we feel in this body. Muscular skeletal common trauma is the commonest one. Like the road traffic accident is the common. But here is that the time pressure, and as you know, in northern Ethiopia there was one. Most of the patients are military one. From the same half year to 3 years before the most of the military. That's what it is. The solution that I just said, we see it is zero. The fact is, what we see is not believe that this factor, but those patients, those who have previously before community survey, there are more like survey classification after they use the my description for this one.
even though they will killing after 2 or 3 days, since it is a complex, most of the patients who have 2 or 3 they need 2 or 3 days, that means initially we make it complex one. So even though the wound is clean after 2 or 3 days, once the negatives are there, can be exactly the probability of surgical certification. Complex others, that's higher. But the recommendation would give a reduced alignment. What it means that show us the complexity of the unit. So as much as possible, until the killing graft to the right 2 or 3 times.
One question to Dr. Solomon. Thank you for your study and presentation. You said that you presented a consecutive series. I noticed that your numbers of male and female advisors were exactly the same. Is that common in pelvic injury that you get exactly the same number?
Okay, thank you, Dr. Chan, for the next question. So in our data, so the distribution was equal, like 74 minutes and 74 minutes. So when you see the 800 in female and male, and the previous study there was significant difference. So as in our study, females have higher than 800 on the copy. Males was during between versus 27 between. So that variation supports this patient-specific variation more for it to happen.
Okay, thank you, our presenters, for the wonderful presentations. You may take your seat. Round of applause for our presenters. Thank you. And thank you for our moderators for the wonderful moderation you've shown us. And round of applause for our moderators. We are now going to go for a very short and very quick tea break, okay? You only have 10 minutes because we want to go home early, right? So 10 minutes, just go grab coffee, grab your snack, you can bring it inside here, and you can have it while listening to presentations, all right? So 10 minutes, max. Yeah, the next presentations are from the science team, so it's going to be very interesting, so quickly.
One of the black line here, one section of the fake crash, and one was the fake. So what because he was a guy who was 2000 so we can discuss with him because there is an recommendation about for the tibia to go for inside. So we have anyway. So Signage doesn't have nail extension, right? We have.
No, we have it. Oh yeah.
No, I know that. It's not.
Oh, you mean just on the brakes?
There are some very one is advanced as a team, we used to approximately second and to traction, because once you have almost we will not operate the patient immediately as we get them. So what we do is the patient contraction, they will say for the long period.
Put to that answer.
So now, just I can say national. What you know about see, I'm and I have a great. So that is one of it's not cast itself, right? It's only second is elastic. Then we have so I'm you can move by you can read even this there is most of them for example, zero to cover at all. And even they see we never have time. And it is low cost. I want to show that how is the cost because I told you it's low cost, trust me, that's some other no, not trust because they need nothing, right? As a the competition. Yes, it's not the same. That which one is like this one? How many percent? How many percent? Okay, I will
Let's open the release. No. Let me get 50? No. Yes. Yeah. feel free, you guys, to come over. I can't imagine how tired we are. You guys are still going 100 miles an hour. I don't know if we trying to let's get back to see if it easier. Yeah. Yeah, this is gonna be this way. Although there's a certain district that I think first license, what things, Great. Thank you so much.
Thank you so much.
Please come inside so that we can proceed. Okay, we're going to continue with our afternoon session. And we're going to have an overview of Science International by Jen. And Terry and Frank from the science team will give short talks. And we'll be followed by Michelle. And it will be followed by a presentation by Dr. Ethiopian and Dr. Vino. They're all going to be very short presentations. They're all going to be short presentations, and I would like to invite the moderators for this session, Dr. Orko, Dr. Namusto, and Dr. Samuel to the stage. And Jen, you can go ahead.
Good afternoon, everyone. Did you enjoy the tea break? Lots of networking going on. Yeah, so I just want to thank you all for the special awards that were given to us earlier today. It means a lot that you need so much, that we need so much to you. So thank you again for that. We are celebrating our 25th anniversary. We were founded by Dr. Zirkle in 1999, and this whole year we've been celebrating we bought shirts, and we're designing new t-shirts for it, etc. So give us a golf clap for that as well. And honestly and very humbly and sincerely, we could not be so successful without your commitment to train, to teach, to learn what you need to learn to give your patients the care that they need. You're giving them the right treatment, and we appreciate that. This is Dr. Zirkle, and as I mentioned before, it's founded by Dr. Zirkle. I am by training a business person, and I've never had the experience of running a nonprofit. That's what we are. We collect donations. We use that to design and manufacture the products that we give to you, and it's a very unusual experience. Instead of a bottom line of profit, we look at the bottom line of the number of patients we can treat. And together, we've been treating, in the last 5 years, we've been treating 25,000 to 30,000 patients each year. So thank you again for your hard work. Did you know that we're here to not only manufacture products, but also train you in the use of our products, as well as other treatments that will help your patients? And we're happy to do it, and we want you to know that we need to hear from you more. Like Claude had said, we need a collection of ideas for what is the priority for the next type of treatment that you need. This is history. Dr. Zirkle started SIGN because in a program he trained orthopedic surgeons in Indonesia. He went back 3 years later and found this man laying in traction. He couldn't afford to buy an implant. At that time, the country didn't even have access to implants. They always depended on volunteers like Dr. Zirkle to bring the product in. And so at that moment, when he saw this patient, and realized that he had only half done the job, he realized that he needed to build on this model of education plus implants so that it could sustain the training that she had been given. And that's how he came about the vision of equality of fracture care. So our mission is to give the poor, injured-poor access to effective and timely fracture care, and we do it through the hands of what we call assigned surgeons. So we rely on you to report your cases onto the surgical database so that we can confirm that the products are being used in a safe and effective manner. And we want to hear your comments as well via the surgical database. These are the products that we manufacture. There's others besides this, but these are the main implants that we manufacture. We are FDA cleared, so that means our health minister gives us clearance to sell in the United States, which we don't do, but also clearance to ship it out. So we wanted the SIGN surgeons to have the best product possible, even though they don't have to pay for it. Our education, as you already know, it's on-site visits, it's the SIGN conference, it's mentoring you through the surgical database, and now that mentorship is being done not only by Dr. Zirkle, but other mentors, we call mentor surgeons, SIGN surgeons around the world. And our SIGN conference has changed quite a bit. It's shrunk in size after COVID. and we do have a bioskills lab, so the process of getting into the sign conference, I apologize for this, but it is a little bit more challenging. But keep asking, and one day that door will open. As you know, we have the surgical database, we also have the hub, and I'm inviting all of you to take a picture of the slide so that you can write to program office and get access to the hub if you don't already have it. It has a lot of really wonderful material and videos, etc., that we prepared for you, and we want you to use it and learn from it. During COVID, we did a lot of webinars. We joined in with IGOT to do those, and we did a lot of online consultations, and we really got to do a lot of interviews because as a nonprofit, we needed to interview the surgeons and maybe even sometimes their patients to be able to tell that story to our donors so they'd be motivated to dig in. So the reason the surgical database is important, it's not just as a mentoring tool to you, it's also an incredible treasure of data. And the last 5 years or so, our engineers have been learning how to mine that data more effectively. We work with IGOT, who also has been mining that data, and some of you in this room have done research from our database. So it's really important to encourage the immediate entry of your cases to the database and to keep your follow-up above 30%, both 6 weeks and 12 weeks. We don't view you as ourselves even as a charity, we view you as a partner in improving orthopedic care, in finding orthopedic truths, and in treating more and more patients with more types of surgery. So we're here to help with that, along with Claude and others who come and visit you. This is what you guys have done. Together with spine surgeons around the world, you've treated more than 434,000 patients. That deserves a clap. We're in more than 450 hospitals in 58 different countries, and we're seeking ways to get into new countries, as we always have done. This slide shows the indications of the normal indications for spine surgery. So it's humerus, femur, tibia. It's also, there's SHT that is also used. I got to speak with some women today who done an ankle fusion. There's also a knee fusion with the side nail, and then the plates themselves are used sometimes in the pelvic area. It's often used in augmenting the nail to create a stronger construct, and we're looking at ways to develop products for the elbow as well. Thank you. And the engineers, Terry and Frankie, will be sharing more about that with you. Nelson Mandela had this saying that he said, I climbed a mountain and I thought I would get a rest, but then I got to the peak and I looked and I saw another mountain. And for us, we're seeing lots of mountains to climb. We made it to 25 years, that's today's mountain. But now we know we need to look into spine, we need to perhaps look into hips, but really what we need to do is find an effective way to gain your opinion about where the direction of spine needs to go. We have invited and he accepted Daniel to be essentially the first spine surgeon to be on our board. He and Dave Shear will be leading out what we call a spine clinical advisory committee. It's an awfully long name, so I always have to look and see what that means. And that's going to be made up of spine surgeons. The first meeting should be sometime before the spine conference, and it will be a webinar type meeting so that they can get together and try to figure out how are they going to answer the question of what are the priorities that you need in LMIC. And then we, the management team and I, have been asked by the board to develop a 3 to 5 year strategic plan. And we're learning how to do that. And one of the first things they ask you to do is take a look at your core values. And our first three at this point are innovative, equitable, and patient-focused. What we mean by equality is in our vision, but equitable is a little bit different. We want everybody to be equal, but they also we have to find equitable ways to help them be equal. So one example I can think of was a 6-foot-tall man looking over a 5-foot fence. You compare that to a 4-foot man trying to look over that 5-foot fence to see the view. And it's up to the 6-foot man sometimes to go find a stool to help the shorter person look over that fence. And that's what we've done in our minds with you. You're talented, you have a highly intelligent, and you're highly skilled. And so we knew that if we gave you the implants, you would give that kind of treatment that is available in the United States. And so we appreciate that, and we know that you're all very conscientious and wanting to learn more. One of the things that happened this was mentioned a little bit earlier today, I don't remember whose talk it was, but amputation is a serious, change, universal body. And during the 2010 earthquake, there were a lot of surgeons from the United States who went into that chaotic scenario and saw injuries that they hadn't really studied prior to going. And they did a lot of unnecessary amputations, and we were appalled by that. We also we didn't do any amputations, we put in a bunch of signals. But what Lou did after we got through with the experience of helping the surgeons in Haiti was we looked at where are the next natural disasters? So, what are the chances that another natural disaster is going to happen in Haiti or Nepal or wherever? And then we focused on starting sign programs in those areas. And what transpired was over the next several years, they didn't ask us for help, but they did ask us for sign nails. They already had the equipment, they already had the training, and when they got close to running out of the nails, they called us and said, please send more. That is what we feel is the most appropriate way of handling first responders. Be before first, and that's what we did. So I was in Bruce's office and I saw this and I thought, this is really amazing because our little sayings of innovation, compassion, and all those other words, it's true. We have those feelings, a lot of empathy. But if you really let love lead you, you're bound to always do the right thing. And I can sense in yoga that is what you're doing. I feel love when I'm here, and Terry, thank you. I feel very welcome to be here. So continue with that because it's working. And I think that might be one of my slides. No, it isn't. So the future really is with you. We talk excited about the next generation because it's time to do that. And the importance of building relationships and maintaining those relationships so that you can maintain the trust in each other. That's the way we're going to continue to build the future together. So it's a huge honor for me to be here, especially that I'm not an orthopedic surgeon, so thank you for listening. And I hope you have a wonderful rest of your year. Thank you.
Thank you.
Terry's going to come up now, right?
Yes. So Terry will be talking about sample fracture from the engineer's perspective, and we'll see how an engineer sees sample fracture.
Good afternoon, and thanks for your patience with this. First, before I start, I want to thank Professor Baruch and Dr. Kiprum and Dr. Galatok for inviting us and allowing us to speak. Today I'm going to talk about subtrope fractures in a study that we did from data from the site database. The work was done by Martha Stone, and my name is Terry Smith, and I'm the engineering manager at ESOT. I do have a couple of objectives while I'm here with the presentation. First and foremost, I want to connect with you. I know a few of you, but as Gene said, building relationships, and as Professor Baruch said, is having a science network and collaborating. That is a big part of who science is, a big part of the science. I also want to reiterate what Dr. Zerber said in his video that I want to recognize the great work that's going on in the field. It's often that he and I talk about cases, and we look at cases, and many times it is your cases that he's sharing and pointing out the quality of the work that you're doing. Gene mentioned the science database. It is really important. That there's 3 previous presentations that talk about, presenting cases from the database. It is really important to us. We get a lot of feedback relative to our devices, and also gives us feedback on the training that we do. And then lastly, I want to learn from it, because I think that I will. I do have to say, yesterday, I spent a little time with the group, and Dr. Moore and Dr. G, and we were, I learned a lot in about an hour. They taught me so much. So I will talk. So the goal of the study, obviously, asked the engineering team to look at subtropic fractures, and in particular, he wanted us to see if we could identify how to improve outcomes, and also what he really wanted is to see if we could identify indications on where we would have a plate standing now. We included cases from February of 2018 to May of 2022. They needed at least 90 days of follow-up, both male and female patients greater than 15 years old, and of course treated with one of our males and with or without plates. And by default, they became some hospitals. A little bit more on the surgical database. We asked the participating surgeons with this enter case information, and that will be a little bit of patient information about the surgery, and also information on each fracture, and importantly, the most important part, I think, is the follow-up information for each fracture. A couple of highlights right now is in the last week, there's over 228,000 cases. That represents about 243,000 fractures. And I will point out, if you go down here to the bottom, there's 115 cases with follow-up. So that's kind of the trend that we see. About half the cases get reported in the database, and about a quarter of the cases then get ordered for the nails, which they should have follow-up to them. We excluded fractures where there may have been a disease, additional trauma that occurred post-surgery. And then we also looked, there's a number of cases that were not subtropic fractures, or they included femoral neck or intertropic fractures, and we removed them from the data. And then if it was not assigned implant, we removed it. So if we look, we started with 430 cases to review from 79 hospitals. We eliminated, excluded 290 of those, and we ended up with 221. The majority that we removed were from the erroneous reporting category, and you can see that the was the next types. We did use the 2-step method. We exported data from the database, and then we reviewed X-rays and reported information from those X-rays. We started with some patient information, and then we really relied on the follow-up information. And in particular, there's a question in there if the patient can walk without pain, and then the surgeon notes if healing is started by X-ray. We then reviewed pre-op, post-op, and follow-up X-rays, and just to kind of be conscious of time, I'm only going to look at 4 things here. So we also broke the subtrope region up into 2 zones. We noted which zone the fracture was in. And I'll talk about that in a second and explain those zones. We looked at the reduction quality at post-op. We looked at to determine if the plates were contoured and matched the bone. And probably one of the more important aspects, we looked to see if the interlocking screws, both the proximal nail and the distal nail interlocking screws were long enough, and if they achieved bicortical fixation. So as I noted, we broke that subtropical region into two zones. You can see that with the red line and the green line. We started at the center of the lesser trochanter, and then that's for zone 1, and then went down to where the canal shape really starts to change dramatically. It was a little bit subjective, but we were able to just kind of categorize it. So if a fracture went through the red line, that we considered it a zone 1 fracture. Just a quick look at some of the numbers. You can see that 87 cases only used the nail. There were 134 cases that used both the nail and the plate, and most of the time a standard nail was used. Those of you that are not familiar with our nail configurations, what we call our standard nail has both proximal and distal interlocking holes, and then our thin nail only has proximal interlocking holes. For an outcome measure, we looked at the painless weight bearing and X-ray, taken by X-ray, and if both of those were marked no, then we consider that a negative outcome. Or if there was a revision surgery that was required after the initial surgery to correct something, then we also consider that a negative outcome. So the results of that, looking at those cases, there were 27 of the 221 cases, or roughly 13%, that had a negative outcome. And so for me as an engineer, it's just a number, but I'd love to hear from the surgeons to understand if you think that's a high number or a low number. If we just kind of generally look at the data, patients, and some of this is really all that, I don't think it's too surprising. The patients over the age of 49 tended to have higher failure rates. The leg treatment was not, really didn't affect the outcome very consistently. The reversal oblique and transverse fractures had the highest negative outcomes. And the next one is probably one maybe surprising a little bit more. 24 of the 27 negative cases that had negative outcomes were in zone 1, so that more proximal fracture. And then the medial fragments, we also noted if there's a medial fragment on the post or in the pre-op, and if that really wasn't a factor in any of the cases. So a couple of quick observations. Unfortunately, we were not able to give Dr. Bergman an answer on an indication when it would indicate to use a plate. I think we did identify a few outcomes or things that could be worked on to improve the outcomes. So that was due to three things. The nail interlocking screws were too short on a number of the cases. I'll show you numbers here in a minute. And they were, so there was not a bicortical interlock on the nail. There was poor reduction at post-op on a few cases, and then the plates were not contoured. They were less straight, or there was large gaps standing off the bone. Now, maybe to give a little bit more clarity on the nail interlock, we did note, though, if there's at least one proximal and one distal screw that were showed a bicortical interlock, there's a much greater outcome to success. There's a quick picture for our interlocking screws. We consider a bicortical that 2 to 4 threads are sticking out the far cortex, and if there's a couple millimeters or a couple threads sticking out on the mid cortex. Also, if you notice the red line, that's kind of a line lined up with the medial cortex of the femur. And so if the tips of those threads, of the proximal threads, stick past that, we consider that bicortical for those two proximal screws. So if we look at the negative outcomes in the Venn diagram, because I'm an engineer and I kind of like these things, you can see that there were 21 instances where the interlocking screws were not bicortical. There were 16 instances where the plate was not contoured. There were 15 instances where there was poor reduction. So the overlap that you see between bicortical screws being the interlocking screws not needed by cortical and port reduction. Those were where 5 cases had that combined. And so with that, I think for us as engineers, we like good structural context. So I do have a couple of requests for you. We would like to understand the challenges with our system in placing those proximal screws and making them more portable. If there's tips and tricks that we have with respect to any of these, we'd like to hear back from you. If there are challenges on bending our plates to get them to match the contour of the bone, again, more feedback for us. If you see any changes that we should consider in our technique, I know placement of our nail getting more immediately is done a lot by surgeons, particularly on proximal femur fractures. So I'd like to understand how prevalent that is, and if that's something we need to consider in some of our techniques. And then you can send that to me, or we can talk about that afterwards. So what are my take-home messages for you today? I guess I want to make sure you understand the importance that we see in the data that it provides us. It provides us a view into our ability to provide training, the quality of the training, that we get a chance to see how effective our devices are, and also gives us a chance to interact with you and understand your challenges a little bit more. I'm going to share a little bit of wisdom that one of my early engineering mentors gave me, and he said, structurally, if it looks good, it is good. And so I think if I translate that into orthopedics, I look at this X-ray and I say, wow, that was reduced well. Those interlocking screws were placed very well, and that plate was placed very well. So I'll let you translate that into your orthopedics and the challenges that we face in an operating room and trying to make that happen with the instruments that we have. And then, I just want to reiterate what has been said many, many times today about the value of the science family networking, and that we do value your input. And I'm going to give you a chance now to maybe practice that. If you don't, because there's somebody in the room who happens to have a birthday today, and today is Jean's birthday. So it is. So what I request of you is that you open your phone and add a calendar event so that every year you can email it and you can wish her happy birthday. So I'm going to leave this slide up for Brooke, are you going to lead us in singing? No, I'm just kidding. Oh, okay. I may not be back next year because I may be fired after this, so I may have a new job. On behalf of the engineering team, on Dr. Zirkle, I just want to say thank you. And I'll try to say that I was thinking Nali.
Yeah. Happy birthday. So Frank will continue with updates on new products and prototypes. All right.
Good afternoon, everyone. First off, I'd like to say that I feel very honored to be able to be here this time to speak, so thank you very much. So, for those who don't haven't met me yet, my name is Frank Chavarria, and one of the engineers on the science staff. Many of you know that Sign manufactures implants and instruments and works with surgeons to educate, but we also work with surgeons to try to understand growing needs. And some of those needs Sign may be able to help with. And this may include new products. So today I'll be presenting 4 challenges that we have received through surgeons, as well as ideas that have come up to potentially solve those. So these are not products that are ready to ship. These are just ideas. So napkin sketches that we've been able to make concepts on. So I'd love to get feedback on this. And because many minds is better than one, I would love to get your feedback. So when you're in conference, I'd love for you to come talk to us and see what you think. Get feedback on us. So the first challenge was, can we create a strong and low-cost plate to cover a subset of commercially available plates, specifically with focus on the distal humerus and forearm? So an idea that came up was a universal elbow forearm plate. So I'll quickly go through some of the details of this idea, and I'll start with the thickness. So the thickness of this, we tried to maintain what our current FX plates have. And through testing, we found that our current FX plate, which I'm sure some of you may have seen, has been tested and is shown to be equivalent, slightly stronger than certain recon plates. So we wanted to maintain that. We also tapered the ends to have a lower profile if there are bony component areas. K-wire holes to better hold the plate while screws and screws are being inserted. We have variable hole spacing on each of the sides so that they can be used to adapt to fracture severity and location. So they can be flipped depending on the need. And screw slots in the center for 3-5 to help with strangulation and fracture compression. Reduction in the neck area to aid bendability. So these are intended to be bended in 3 points. The hope is that this plate could be used with our existing Sign elbow bending template. And we have a couple questions that we were just thinking, just initial ones to get gears turning. Is the plate length adequate? The width of the plate adequate? Are there holes or features that need to be added? These are great feedback that we can use to kind of help this design move forward. The next challenge for certain fractures was, can we expand the capability of our existing FX plate? So the second idea, on the left here, you can see the existing FX plate. Can we create augmentation plates? So this time we're exploring certain configurations, like the T plate, L plate, cobra plates. And these plates can be bolted on or using the existing, the actual 3-5 screws actually connected to. We still have testing to do, but this is an idea to help expand that. And these can be used to stabilize fractures in the distal femur, proximal humerus, the plateau, the next challenge was for distal femur fractures, specifically noting that extra articular fractures that maybe need more fixation than L alone can provide. So this led us to a third idea, which is a 2 large hole FX plates, trying to create a construct that has the ability to connect both the nail and the interlocking screws. So our current FX plate, because of the hole spacing, would cause the screws to converge because the spacing doesn't match the nail. And I know these plates aren't contoured for that image, but just to give an example. And with the slot on this plate here, after we're able to connect the nail interlock, you can see here that we would have parallel screws, giving better likelihood of getting that bicortical fixation with the screws that are long. The next challenge was for femur and tibia intra-articular fractures. Can we create a plate to stabilize that area? So the last idea is a cane style plate. So it would connect to the nail interlock similar to our existing index plates, but it would allow for 3 to 5, or potentially we increase the size, compression screws on the most distal end there to help support and stabilize maybe fragments that are on that area. So our request again is we would love to get your input on these designs as they're very early in the development process, and help us with extreme needs so we can make sure that we're focusing our efforts here at Sun. There's a lot of problems that we can work through, but by working together, we can focus on what's in those. I have a final request, and that is that we have an engineer on our team that is making a playlist currently, and we'd love to see if you would contribute to that list, and if you could add maybe your favorite artist or song, you can either email to Joe Gillard or use that there. We have our events and conferences as well, and just for our science staff, we'd love to know music that is listened to at all the programs that we work with. So we'd love to get that. Thank you.
Next presentation is going to be brutally and confined on functional determinants of factors, subtle fractures, categories, sign and parameter naming in a succinct setting. Okay, good afternoon. I know everybody is a bit exhausted right now, so I'll try to go through my slides as swiftly as possible. So our study aimed to see what the functional outcomes of subtrochanteric fractures were treated with sign intermediate. The study was done by Dr. Hartog, senior consultant at St. Paul's Hospital, and myself, a senior resident at St. Paul's. So a lot has been said about subtroch fractures. I will not repeat that, but it definitely poses a challenge to the treating surgeon due to several factors. Currently, it's intramedullary nails that are preferred as the preferred management option for subtrochanteric fractures or subtrochanteric fractures. However, these implants are not available readily in every setup because they are expensive and they require regulars and cables, and also intraoperative fluoroscopy, which may not be available right and left. So silent intermedullary nailing offers an alternative, and these nails can be used without these expensive gadgets. So for common fractures, which are considered unstable, surface wires or augmentation plates can be used, and this functional outcome of patients managed with this novel treatment method hasn't been studied extensively. Hence, we aim to study the functional outcome and associated factors of patients with subtrochanteric fractures with this sign intermedullary nailing. And we also wanted to determine the associated factors with these fractures. So our study was designed as a health facility-based cross-sectional study. The study area and duration was at Abbott Hospital, and the study period between 2015 to 2021. We included all patients with subtroch fractures treated with sign nails, and we excluded those with atypical subtrochanteric fractures, those with incomplete follow-up, and those with previous pathology of ipsilateral extremity. So we used a single population proportion formula to determine our sample size. There were a total of 82 patients which fulfilled the inclusion criteria. However, unfortunately, we had to exclude around 39 of these patients because they had incomplete data or they were lost to follow-ups. So these were our variables of our studies. I'll discuss them later in the results section. So we used the modified Harris score to determine the functional outcomes. The modified Harris score has two components: pain, which was scored out of 44, and function, which was scored out of 47. The two sum up to give up 91, and then This was multiplied by a factor of 1.1 to give a score of 100, and a score cutoff of 80 was used for good functional outcome, and score less than 80 was considered patients without poor functional outcome. So we used a study-specific data collection form to collect the data from charts from the scientific database and from the radiographs. So we used means and percentiles to summarize the descriptive data, while logistic regression was used to check for associated factors, and p-value of less than 0.5 was considered significant. So coming to the results, we had a total of 43 patients. The age range included patients between 18 to 80, and the mean was around 31.7 years. Males accounted for the majority, around 81%. 80% had associated comorbidities, and hypertension was the most common comorbidity that we found. Coming to the mechanism of injury, we found that motor vehicle accidents accounted for more than half, which was around 55.7, followed by bullet injuries for around 23.3, and then falls from heights and simple falls, and other mechanism of injury associated for the rest. So coming to the associated injuries, we had 1/3 of our patients had associated injuries, with 4 patients having gips, lateral extremity fractures, 3 patients having head injuries, and 2 patients having thoracoabdominal injuries. Open fractures accounted for around 27.2, and then closed fractures accounted for around 72.1%. So looking at the implants that were used to stabilize these structures, isolated standard sinomegalia were used in around 49% of patients. Augmentation was side-plated was used in 26%, and augmentation with circulate wires were used in around 18%, while 7% of our patients had augmentation with both the circulate wires and the side-plating together. Another interesting finding that we saw was blood transfusion accounted for around half, which was a pretty alarming finding. Most of our patients required at least 1 unit of blood transfusion, either pre-operatively or post-operatively. Another interesting finding was that the median time from injury to the surgery was pretty delayed. It was around 15 days. Average procedure duration was around 118 minutes, which was around 3 hours, which shows how difficult treating these fractures might be. Average hospital stay was also long. It was around 21.6 days. And the median Harris score we found was around 85.8. With functional outcomes accounted for around 67.4, while the remaining 32.6 had for functional outcomes. So we ran a binary logistic regression to check for associated factors. We ran bivariate analysis, and then we followed with multivariate analysis to control for the compounding factors. And finally, we found that age and requirement of blood transfusion had statistically significant association with poor functional outcome. So every year increasing age increases the likelihood of having poor functional outcomes by around 90%, while requirement of blood transfusion significantly increased the association with poor functional outcome by around 8-fold. So these were some of our patients we included in our study. Here you can see that fractures were pretty complicated, but at 12 weeks follow-up, our patients had adequate healing, as you can see with the squatting smile, which is depicted on the right side of the screen. So we had comparable findings with the literature, and we also had some conflicting findings. The comparable findings were with the functional outcome. We found around 67.9% of our patients had good functional outcome, which is comparable to a study which was done in India, where around 70% of patients had good functional outcomes when treated with acetaminophen. Other comparable findings were associated comorbidity was present in around 22%, and also associated injuries. The findings were also similar. So conflicting findings, age and gender distribution differ significantly. Female and elderly were common in the literature, and ours was males. Mechanism of injury was also different. Simple falls for the literature, and for ours it was motor vehicle accident. And also the duration of hospital stay was pretty long, time for injury, and requirement of blood transfusion was also significantly different finding. So we had pretty high limitations for our studies. One was a retrospective design, and the other one is a small sample size, which is a frustration that most researchers have when dealing with research in our setup. And another interesting limitation was that we included potential co-founders, where we included open fractures and patients with natural large fractures in our study, which could negatively impact the proportion of patients with good functional outcome. So as a conclusion, our second actionable evidence that science can be used as a alternate treatment option for subtraumatic fractures, especially in limited setups like ours. And we need to optimize patients and prevent the inappropriately, and tailored approaches to elderly patients may be recommended. And we advise on further research to address the limitations of our study. This was my presentation. Thank you. The last but not the least presentation on the day of this annual meeting is going to be presented by Dr. Ethiopian, removal of broken solid intramedullary nail of femurs. This is a case report. Very interesting. You may have sessions in your parents. Okay.
Good afternoon. Thank you for your patience. It's a great pleasure to present on this presentation and improve the science in this challenging broken nail removal. I will present a case we faced in Bloodline Hospital. Local dimensions is a traumatic Bloodline Hospital, and me for the Bloodline Hospital. So these are my contacts. I will focus on the case presentation and our removal techniques. So, broken nail is a rare complication. It stands to mean it's a rare complication, but it is a very challenging procedure. As you know, the nails can be cannulated and solid nails. For those cannulated nails, there are different options of removal. Because using this cannulation, we can use with this cannulation, we can use guide wires and hook to remove the broken distal nails. Otherwise, we can also use the cortical removal of the distal ligament, and we can push the broken distal segments. And also on the distal area, there is a technique using Edman pin with the levering technique to remove the distal ends of the broken nail. So, in general, removal techniques for solid nails like sine nails, removal techniques are limited, and the risk factors for implant breakage are improper implant positioning, malreduction, delayed and non-nail, which is the case present with nails. So our case is a 60-year-old male patient, is a diabetic patient. He was sustained traumatic injury 12 weeks back, diagnosed with the right knee and treated with retrograde timing. He has also patellar fracture treated with circular wire, and I think he has severe fracture with the medial plate. So after the treatment, he was comfortable and he had no pain and he was working and doing exactly this way. But in the last 2 years, he started to complain thigh pain and knee pain on the right side. Otherwise, he has no history of trauma. And on clinical examination, the pertinent ones, he has limited lesion to 90 degrees. And we x-rayed him at the OPD. And as you see on the X-ray, there is a broken nail with a broken proximal dynamic screw, interlocking screw. And also you see the prominent screws on the tibial club. You can see the broken nail on the lateral leg side anyway. So with this broken nail and fractured nail, we plan to remove the nail and the prominent screws. So our preoperative plan was to remove the nail with anti-grade injury. So as you see on the first image, after we use the interlocking bolt of the side nail, we easily remove the proximal segment and we remain starting of the broken nail. So as you see proximally, we made a standard GT3. Then we read proximally, sequentially we read proximally, and the challenge was it's difficult to engage with the side of the broken knee. That's because medial and the lateral as you see, and we try to use the proximal part of a broken knee to engage in the to impact to the knee. But still, we have the difficulty of engaging the tip of the knee because our injury was a bit lateral. Then we don't go with the removing in anti-grade fashion. So we use the tip of another broken nail and we push the nail from the knee to the piriformis. So we remove it proximally, and you can see the broken screws and the broken nails. And for the laminate, we manipulate the structure side as we overlaid the initial nail was 9 by 38, and we extended with 11 by 40 millimeter nail. Then the post-operative stay after 9 months, still the fracture is not united, and the patient has arthritic changes and has mild knee pain, but the neck pain is not as previous one. And we are planning in the future just to take a graft and manage the enemy. So, the enemy is a major cause of implant breakage, and the proximal bone is the weakest part of the neck, which is commonly broken, and we can remove either through the piriformis injury or retrogradely, but using a lateral injury, we face the same problems like us. And our technique doesn't need any cortical windows, any other bony and soft tissue dissections, and we can do it with another broken nail without the need of special extraction devices in the resource limited setting. So removing the distal of the solid nail is a challenging procedure, so we have to be prepared well initially, and as much as possible we have to prevent managing a broken nail. I know most of you will face a broken nail, you may remove it, and in case you will remove it in another way, but this was the way we tried to remove it. Yes, we use the serum and the limits are hopefully they will help you to check in such similar cases. Thank you very much.
Thank you very much. Thank you all those persons. So thank you for the same family to present a interesting talk and inspiring one. We are very happy to see the new development of science plan. And thank you both for being present to the research work. Now, due to time constraint, we will accept only two questions. Due to time constraint, we will accept only two questions. So, raise your hand, I will give the chance, then we will stop. Okay, and this? Yes, yes.
Thank you. I will do nice innovative ideas for my creation of some ideas and questions. So it was really interesting to new things. So
the foreign neural plates, the animations you click shows three holes in the three holes. So animations, so these three uses this probably get the bones, so you get the remove this plate, so that process is the next of changes, I think, going to be high because we believe that three processes is not so how do we see so I think for this. So the 9 weeks, the patients concerning the candidates, especially for the period for the standard approximately here we have 8 weeks of the legal cycle approximately. So putting this kind of the large rating over the legal aspect of the day is going to be obviously probably because we are going to look it from the legal side. So opening the large making a large decision of the legal aspect approximately. Then since those kind of because those places we have applied, we need to open it. We need to make the decision of the legal side of the approximately. So another question, so this place are they going to be universal and single size for all, or are they going to produce different sizes? Because even the smaller ones will be for society. And the same place will also decide for the lateral aspect of functionality. So are we going to make a separate decision for that place, or we are going to block from the lateral side? So we decide for both sides of the from the medial side from the lateral side. So the locking notice on the medial side, but we decide for the like the lateral side of the person. If you can hold it, the cages. So what was it like? Are you going to change the direction of the mail, or I think that's thank you.
Okay, thank you. For the president, so my first question is Simon Jackie. So in addition to what we present on the design of the plants, we have a chapter on fixing the legal factors which are distal and the proximal. So as you see from the sign on the picture, so the distal as well as the distal is low to lock the distal. So to put distal screws. So we need to have more modified form of the sign for distal looking, more distal looking as well as polyartial looking. For the proximal, the same also. That's difficult to block. We send for proximal fractures, something like other implants. So can you consider these revisions for specialty here? Is a question. So the second question goes to Dr. Dina. I think, have you just create a whole multiple forms after you get the GT, or you just cover it from the topic? That's question. The last question is to Dr. Dina. So you showed us there is a significant association for outcome blood loss and functional outcome. But from your paper, the median time of presentation is 15 days. That's been a long time. So there is a significant delay. So how do you correlate functional outcome with this delay presentation? Thank you.
So to answer your question, as far as how many holes for the plates that we have there, that's still something we're looking into. So that's the feedback that we really want to get. So that's a great question on that piece. As far as the As far as the other question, if it goes to the tibia, whether it was going to be the lateral medial side for the plate, is that the second question? So that's the other piece that we were also wanting to get feedback on. I know that coming from one end versus the other, having a target around would be able to do that. That's something we also want to discuss.
I think your question was on the standard nail, if we could shorten the tip, so you could do the interlocking more distally. That's something that this is starting to come up a little bit more, that question is, and so it'll be part of our evaluations. We look to make changes to our system, and it's a balancing act of trying to know how to spend the money. So is it possible? It is possible, and it'll just have to fit in the priorities of some of our other projects. So.
Okay, thank you for the question. Yes, you're right. The requirement of the transfusion was associated with an 8-fold increase of increase that you put a poor functional outcome, and also that transfusion requirement for patients either pre-operatively, intraoperatively, or post-operatively was around 46%, which we did not expect. So we had so many confounding factors that the take-home message from this recent study was, despite all those confounding factors, we had proportionately good functional outcome with the signage and the course of factors. But we recommend further research to be done in order to control these factors and reach a definitive conclusion with regards to these associations that we found.
Thank you, please. And as you see in the picture, our injury was a bit natural, so we couldn't engage the tip of the broken nail. So our reading was more medial. That's why we didn't face the difficulty of removing with the pipe forming. But if we didn't really, we have to make a standard pipe forming simple.
So, thank you very much. We will continue to stop here, but before we finish and take the previous and after the report. Thank you very much.
We celebrated her birthday last year in Tanzania, and this year it is here with us in the program. So we
birthday celebration, don't tell them that this is much better.
So we really appreciate your work. So we are really pleased to have you here. We love you all. So happy birthday. Thank you, thank you for letting us surprise you. We really appreciate it. Okay. I know there is a much. I guess that's a place to entertain natural. So somehow pressure. Basically, our housekeeping issues and I decided to do with you. I hope you really enjoyed our stage. There were some inconvenience, right? So we really appreciate all the hard work that you are also and also for your patience and staying all this time with us together. And the membership duty, the full active members that I get less on the Sarat. I hope to do just for a yes, please respectfully membership duty and tomorrow we start at 8:30 and then other responses like the video so we can know the video. So hopefully traffic jam we can solve as well. In traffic jam on the day that we and then again it's and we did the magazine that we the pay Bagi Putrana. So very difficult account Chamari the department la membership. Either to the table Telegram, those are the Zoom and Telegram, so it's going to be we need you to have it. And Dr. Noah, if you did honestly speaking, so better CPR already, the government topics, this job already gets a lot. CPR and CPR ESOT. So here in Akatari, then grow hopefully this is the city accredited to also to this national symposium fully accredited full participation around CEOs, the presenters, CEOs, and series of lectures presented as CEOs, the sponsors, the CEOs, certificate already prepared with your own name and also identification numbers. And hopefully, tomorrow, having today, there's your presence in the full participation expected in the AGM, fully. ብዙ ዲሲሽኖችን መሰለን የሚስማማው ሁላችሁም ያላችሁ ጥያቄ ለዛቀር በጋራ መስተካከል መወሰን ያለበት ኢሹዎች አሉ። እነዚህ ኢሹዎች አዲስ ማለት ይቻላል። ያው ሁሉ ጊዜ የምናደርገው ሰከንዳሪ መንተባተቦች አሉ። ፕሊዝ ከዚህ መጥራት ያለበት ነገር ስለሆነ ነገ ፕሬዘንሳችሁ ሪኩዌስት አደርጋለሁ። ነገ ሆፕፉሊ በፉል ሜምበር ክሩ AGM ማጠናቀቅ ተገቢው ሳይንስ ወስነን ለቀጣዩ አንድ የሚዘጋጅ ማለት ነው። ዘንድሮ ላይ ያሉት ላይቭ ስትሪም እያደረግን ነው። ሶ መምጣት ያልቻሉ ነገሮቻችንም ዩቲዩብ ላይ ያሉ ቴሌግራም ላይ ያሉ ነገሮች እናስባለን። ሶ ቢግ ቼንጅ እንደዚህ አይነት ነገሮችን ይቀጥላለን። ነገ በተመሳሳይ መልኩ ይቀጥላል። በግሩፕ ላይ ዩኒቨርሲቲ ነው ምን ያሁንም So never hopefully የከፈላችሁበትን ክፍያ ስክሪንሾት ስታሳዩአቸው ደረሰኝ መውሰድ ይኖርባችኋል። ግዴታችን ነው። የከፈላችሁ ኦልሬዲ ደረሰኝ ተቆርጧል። ነገ መውሰድ ትችላላችሁ። ከነግስ ዛሬ ለምትከፍሉ ነገር ለምትከፍሉ ደረሰ እየተቆረጠ ይሰጣል። ሰው ደረሰኝ ውሰድልን እንዳትረሱ ማለት ነው። ሌላ ጨምሮ ሀሳብ የለኝም። ስለነበረ ጊዜ ስለነበረ ቆይታ በጣም አመሰግናለሁ። መልካም ምሽት።
Yeah.